Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to episode 3, the concluding episode, at least for now, on lymphoma for radiology board review. Remember to download the free study guide on lymphoma, which I will make available on my website, theradiologyreview.com. You can find this and other free downloadable study guides that can potentially assist you in your board study or educational needs. Without further ado, let's get back to the questions and answers. What are classic imaging manifestations of Hodgkin's disease? This is a basic but important question. Hodgkin's lymphoma typically manifests as lymphadenopathy that starts in the chest, axilla, and or neck, so typically upper body involvement. Extranodal disease is not common in Hodgkin's disease. So I would remember that Hodgkin's lymphoma is most commonly lymphadenopathy in the upper body, whether chest, axilla, or neck. And when I say chest, that includes the mediastinal and hilar regions. Extranodal disease is not common in Hodgkin's disease. However, in advanced cases, any organ or tissue may be involved. So, with Hodgkin's lymphoma, this is no exception that any tissue in the body can be involved. When extranodal disease is present in Hodgkin's disease, this is often seen in the bones. And with bone involvement of Hodgkin lymphoma, this would typically present as a lytic lesion earlier on and as a blastic lesion later on. So there can be the transition from lytic early to blastic later within the bones. Slightly less common than bone involvement is lung involvement, and with lung involvement you can see direct extension from hilar lymphadenopathy into the pulmonary parenchyma with soft tissue. Look for anterior vertebral body erosions on a spine film, and that can be caused by paravertebral lymphadenopathy that erodes the bones. And you can also look for an ivory vertebrae, which is a single high-density vertebral body. If you see that single high-density vertebral body, that is not necessarily pathognomonic for Hodgkin lymphoma, but it can be seen with lymphoma or other diseases, to include other metastatic disease, tuberculosis, and Paget disease. Next, what entities are part of the non-Hodgkin lymphoma family? Non-Hodgkin lymphoma is a catch-all basket for pretty much everything that is not Hodgkin's lymphoma. There's probably some exceptions, but in general, that rule will get you through a lot of questions. This includes things like Burkitt lymphoma, mantle cell lymphoma, follicular lymphoma, T and NK cell lymphomas, and post-transplant lymphoproliferative disorders. Those can all be considered part of the non-Hodgkin lymphoma family, so lots of different types of lymphoma belong there. Next, what is the most common subtype of non-Hodgkin lymphoma? The answer, according to what I've read, is that diffuse large B-cell lymphoma is the most common subtype of non-Hodgkin lymphoma. Less aggressive non-Hodgkin lymphoma subtypes, such as follicular lymphoma, can transform into the more aggressive diffuse large B-cell lymphoma over time, so be aware of the potential of less aggressive lymphomas to transition into a diffuse large B-cell lymphoma, which is the most common subtype of non-Hodgkin lymphoma. If you see images on a question of an indolent lymphoma that rapidly progresses on imaging, then you should consider diffuse large B-cell lymphoma in the differential. If this is a kid, especially if it is a boy in Africa, that presents with very large nodal disease in the neck or face region, you should definitely think of Burkitt lymphoma. Burkitt lymphoma is also super common in the abdomen, so look for large masses there. If you're looking at an adult with follicular lymphoma and things seem to be progressing really rapidly, you need to consider the possibility that the follicular lymphoma has transformed into a more aggressive diffuse large B-cell lymphoma. Next, true or false? Most cases of post-transplant lymphoproliferative disease occur greater than 1 year after organ transplantation. The answer is false. Most cases of PTLD, or post-transplant lymphoproliferative disease, occur within the first year after organ transplantation. Next, common treatments of post-transplant lymphoproliferative disorder include what? A reduction of immunosuppression may be the first thing that you would try to treat PTLD. Back off on the immunosuppression and see if the PTLD improves. However, you have to strike a balance between the risk of PTLD and the risk of transplant allograft rejection, because the immunosuppression does have a purpose, which is to prevent allograft rejection. So a balance is needed. Other treatment options can include surgery, radiation, and chemotherapy, but I just wanted to point out that one treatment of PTLD is to back off on the immunosuppression. Next, what is the hallmark genetic translocation in cases of follicular lymphoma? Knowing some of these genetic aberrations can help you get board exam questions correct. So, the hallmark for follicular lymphoma is a translocation of chromosomes 14 and 18. Next, what are some classic cytogenetic features of diffuse large B-cell lymphoma? Can you think of some gene aberrations that are common with diffuse large B-cell lymphoma? Well, I'll have 3 for you. One is BCL2, the other is c-MYC, that's C-MYC, and the other are BCL6 rearrangements. So c-MYC, C-MYC, BCL2, and or BCL6 are common with diffuse large B-cell lymphoma. Next, what is the Deville score? I already mentioned Lugano classification. We also need to discuss Deville score. What is the Deville score? The Deville score is a 5-point score for use of staging lymphoma based on degree of uptake on FDG PET-CT. So with Lugano, you can stage the patient with CT scans. However, to assign a Deville score, you need an FDG PET-CT scan. The key is to remember that a score of 4 or 5 means that you see uptake in lymph nodes or other organs involved with lymphoma that is above the liver. Okay, if you see uptake above liver, that is a Deville score of 4 or 5, and that denotes that there is active disease or progressive disease, depending on how the prior imaging showed. But either way, this is a bad thing. You do not want Deville scores of 4 or 5 because that means the lymphoma is thriving, even though you have been treating it with chemotherapy or other therapies. If you see new disease that is hypermetabolic, that is automatically a Deville score of 5. So remember that. New disease equals Deville of 5. On the other hand, a score of 1 to 3 denotes absent uptake, which would be a score of 1, or uptake below that of liver, which would be a score of 2 if the uptake is below liver and below or equal to blood pool, or a score of 3 if the uptake is above mediastinal blood pool but below or equal to liver. Okay, above liver is 4 or 5. Equal to liver would be a 3. Less than liver would be a 1 or 2. Next, which Deville scores can denote a complete response to therapy Notice I said scores, so there are more than one. Which of the Deville scores from 1 to 5 can denote a complete response to therapy? The answer is that Deville scores of 1, 2, or 3 can denote a complete metabolic response to therapy. On the other hand, Deville scores of 4 or 5 denote stable disease, progressive disease, or partial response, depending on whether uptake is the same, which would be stable disease, better, which would be partial response, or worse, which would be progressive disease. To recap, a Deville score of 1, 2, or 3 can be seen with a complete response. A Deville score of 4 or 5 can be any of the following: stable disease, progressive disease, or partial response, depending on whether things are the same, better, or worse compared to the prior imaging. And remember, a Deville score of 4 or 5 means that these lesions in the body have uptake above that of liver on FDG PET-CT. A bonus tip is that it is possible to be considered a complete response when using a Deville score, even if there is a large residual soft tissue mass, as long as there is no uptake or very low uptake within the mass. Okay, sometimes lymphoma resolves metabolically before anatomically, but if there is no or very low uptake within a larger mass, that can still be considered a complete response, at least a complete metabolic response. Next, diffuse bone marrow uptake can be a sign of lymphoma involving the bone marrow, but diffuse bone marrow uptake can also be seen in what other settings? Another way to phrase this question is, what are potential confounders for increased bone marrow uptake that can lead to a false positive interpretation when evaluating lymphoma on an FDG PET scan? Diffuse bone marrow uptake can be seen with lymphoma, but it can also be seen in other settings to include bone marrow stimulation from colony-stimulating factor agents such as filgrastim. It can also be seen in the setting of bone marrow rebound if you image closely after chemotherapy, or bone marrow rebound from other causes of anemia. So if you see diffusely increased bone marrow uptake, you need to check whether the patient has received recent filgrastim or other colony-stimulating factor agents. You should also check how long ago the patient has had chemotherapy. And if you are imaging very close to chemotherapy being completed, you can see the bone marrow rebound that is due to that. In some cases, you can also see this with anemia from other causes where the bone marrow is really ramped up, trying to increase the blood counts. Additionally, sometimes you cannot tell what is going on, whether increased bone marrow uptake is due to lymphoma or other processes. And that brings us to the next question. How can bone marrow involvement of lymphoma be confirmed? I hope for radiology residents this is an easy question. The answer is that bone marrow biopsy is frequently performed as part of lymphoma evaluation and staging. To confirm bone marrow involvement of lymphoma typically requires a bone marrow biopsy. These are most commonly performed in the iliac bones from a posterior approach. So on imaging, if the patient has had a recent bone marrow biopsy, which is common when you read FDG PET scans, look for linear subcutaneous fat stranding and uptake that extends to the region of the posterior iliac subcutaneous tissues and bone. Additionally, within the iliac bone, you can sometimes see linear uptake as well. And that should confirm to you that the patient has had a recent bone marrow biopsy. Next, how can you differentiate between brown fat uptake and lymph node uptake on FDG PET-CT? This is my second to last question, and it's an important one. How do you differentiate between brown fat uptake and lymph node uptake on FDG PET-CT? I am assuming that most of you have heard of brown fat. This is a certain subtype of fat that can help warm the body. And as it warms the body and creates that thermal heat, it takes up a lot of sugar. So you can see a lot of FDG uptake within brown fat if that brown fat is active. Obviously, another term for brown fat is brown adipose tissue, so we're talking about the same thing if you see that term. And brown adipose tissue can look very similar to hypermetabolic lymphadenopathy on FDG PET images. So on the MIP of the scan, or if you're looking at the PET-only images, you'll see a lot of uptake. It will look like hypermetabolic lymphadenopathy. However, the key is that you must evaluate the CT images to see whether the uptake is associated with lymph nodes or if the uptake is seen in a region that only shows normal fat. If the uptake is in a region on CT that only shows fat and there are no abnormal lymph nodes in that area, then you need to start thinking about whether this could be brown fat. The most common locations for brown fat uptake are the mediastinum, the neck, the supraclavicular regions, the paravertebral regions, and the upper para-aortic regions. You must carefully scrutinize areas of brown fat uptake to see if there are coexistent lymph nodes, as you can have mixed lymphadenopathy and brown fat uptake at the same time. If areas of uptake correspond with lymph nodes, this is potentially pathologic. If areas of uptake show only fat on CT and it's in a characteristic pattern, which is usually bilateral and somewhat diffuse, then consider this brown fat uptake. Note that brown fat uptake is a potential cause of diagnostic error for lymphoma staging, and it is also commonly tested, so it is important to be aware of this entity. Next, what can be done to minimize brown adipose FDG uptake? Because this is a potential cause of a diagnostic error, we do want to minimize uptake in brown fat. What are some strategies that you can employ to reduce the uptake of brown fat? This is a high-yield question. The answer is that there are various strategies that exist, and these include warming the PET uptake room where the patient will wait prior to PET imaging, so have warm spaces. Because if the patient is cold, that can activate the brown fat. You can also administer medications such as benzodiazepines and or beta blockers, and that would be most common to consider for patients who have had prior brown fat uptake, so you are aware that they are someone who is prone to this. And prior to PET imaging, you can give them benzodiazepines or beta blockers, and that in theory can reduce brown fat uptake on your imaging. Lastly, you can encourage patients to stay warm prior to arriving at the imaging suite for FDG PET imaging. That concludes my review of lymphoma, at least for now. I'm sure lymphoma will come up in other podcast episodes in the future. Again, I hope this is helpful. I appreciate the time that you spend listening to these podcasts. If there's anything I can do to make these more useful for you, do not hesitate to reach out to me. You can find me on Twitter at RadRevPodcast or send emails to theradiologyreview@gmail.com. Also, check out the free downloadable study guide on lymphoma comprising these episodes on my website. Keep up the good work. Study hard. You have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.